So we are on week 5. I think it's probably the hardest, but the areas where you're tested on the most, whether it be in med surg or pediatrics, heart and lungs. And heart in children, there's a lot of differences because of congenital heart defects, but taking and assessing a heart, there's a lot of similarities between the adults and the children. So I'll be going over those differences. Oscar, oh, there you are. All of a sudden, I was going to say, you got a black screen today. It's okay, no worries. Um, we're going to be doing a Kahoots after the PowerPoint. And if you noticed, I did send you what I call an outline. Another professor goes through an outline, and it's basically the chapters condensed with some pictures. I was asked by some students for other ways of looking and learning. So I am pulling together those things for you because I do listen, because we all learn differently. And I also, have a matching. When I was working on ground doing pediatrics, I actually had it as a quiz where it's 20 questions, and it's definitions of some diagnosis, and then you have to pick out what is it. And it literally goes through your book, and every section that's highlighted, bolded areas are covered there. So it really does cover it well. So you can answer that matching. You're doing well. Now, I didn't send you the answer sheet, but what I do is after class tonight, when I send you a recording, I'll put your answer sheet there so you know that which answers you have are the correct ones. Cardiac is difficult. Anybody who needs some extra help with it, just let me know. Amy, you have a question?
So the piece lesson, the document you're talking about, when we click on the announcement, it does not load. Like I'm on it right now and it says error while processing or retrieving this document.
Hold on, let me see if I can do this.
Yeah, I was having
gonna say the same
Okay.
thing.
access
It's
denied.
It
locked.
Thank
didn't
you.
pop up.
Yeah,
No,
yeah,
thank you
mine's
for
locked.
letting me know. All right, let me try something different. Let me try to attach it here. Figure out how to do it again. Technology. Here we go. I'll get it. I will win. See if you can open that. Also, I'm going to put in there the matching one, just in case you don't or can't open that one also. So there are both of them for you.
I'm
Okay?
sorry, where did you say you posted it? It's
It's
in the
in the
chat?
chat. It's in the
Oh,
chat.
okay, okay.
Was it able to open it now?
I don't see nothing in the chat, or is it just me?
Oh, you know something? I just
I
sent it
can't
to
see anything
Jennifer.
either.
Wait, I just sent it to Jennifer.
I'm like,
Hold
what?
on. Jennifer has it. Anyway, let me just redo that. That's funny. What happened there? Let's do that again. Forgive me. Here is the cardiac one. And here is the peds lesson, the other one. Okay, can you open them? Jennifer, were you able to open them? Okay, so she got it, you all got it. Beautiful.
Yes, I can open them now.
Awesome. Thank you for letting me know that. This is actually a really good way to do it. So maybe in the beginning of class, that's what I'll do to make sure, because sometimes it does say error, can't, you need a password, authorization, all different stuff goes on. So, all right, let's go ahead, share screen, and let's start respiratory, and then we'll work into cardiac. Now, what I want you to know about these conditions, that a lot of them are just common sense. and you try to make it more than what it is, okay? And I think this is why I'm good at math because I make it that I understand it. It in my mind works. So as we go through, if there's any areas that you're like, I'm not getting you, stop me. I'll explain it in a different way for you. So we're going to start out with respiratory. Probably one of the biggest things that kids have is something respiratory. They always have mucus and secretions and a cough, and they're always with their hand and wiping themselves, and of course, on their shirt. They absolutely love it. There's upper and then there's lower, okay? Upper is all the upper airway, your nose, your ears, and all of that noise. And then lower would be down, like where pneumonia would be, that lower bronchioles and alveoli. Now, most of the infections in the respiratory system, even with big fevers, in fact, viruses have bigger fevers than do bacteria. When you see big fevers, I know it's going to be an upper respiratory, a viral infection. Most of them are. Now, you can have bacterial pneumonias and viral pneumonias. But usually with pneumonias, we usually will give antibiotics because it is a pneumonia that could turn into it. And there's all different types of organisms that can cause it. Now, what's going on with the kids and as they grow? This is an important concept about a baby born and has mom's antibodies, has mom's immune system, but it starts to wear off and go away. You wonder why we give all of these, immunizations at 2, 4, 6 months. We're trying to give as much protection to that child as we possibly can. Now, at age, less than 3 months, we got mom. If a kid at less than 3 months old is sick with infection, that kid is sick. And that's actually, we have them at high alert if you go into an emergency room. Now, after 3 months, of course, mom's antibodies are starting to wear off. And now it's the baby has to make their own, antibodies. And you're going to start getting more infections. You're going to see more of those ear infections and upper respiratory infections. And we know that toddlers and preschoolers, what do? All day long, everything in the mouth, right? They're in daycare, they are in school, they're sharing, and as I've always said, they swap spit all day long. And there goes all of those, bacterias and viruses being passed around. As they get older, it becomes more bacterial than it does viral because the body's been really exposed. And with that, of course, immunity is much stronger as they get older because of the immunizations, because they've already had these viruses, they've already built up antibodies. So they don't have as much sickness as they do in toddlers. I've always heard parents say, yeah, I'm here every week with my 2-year-old because he just started daycare. And it's a very common thing because they swap spit. Now, one of the biggest things they get is ear infections, right? Why? Well, everything's close together. It's wide open and it's straight. So you get all this mucus in your nose, which they always have. It pushes up to the areas of less resistance, which is up the ear canals. That's why you have a lot of ear infections. The eustachian tubes, they're short, they're open. It's a great way for stuff to go and ear infections. Now, what does a kid look like when they're sick? Well, kids are great because they will show you when they're not feeling well, you're going to see them stop eating and you're going to stop seeing them playing, right? Those are the first things. If a kid's not going to eat a favorite food or snack, something's wrong. If they have pain, they're going to tell you. Younger children, like an infant, they can't say my ear hurts, but you might see them banging their head, or even their hand, or sticking their hand down their throat when their throat hurts. They do tell you, but you have to look for it. We know there's fever. I mean, it can get to the point of meniscus or, a meningeal type of thing. But again, they stop eating. They might vomit, diarrhea. They might have some abdominal pain. They might have that juicy cough, sore throat, and those respiratory sounds. I mean, kids get gurgly and rhonchi everywhere because of all that mucus in their upper airway. Now, how do we take care of kids? Well, you have a kid who has a problem not breathing. You want them to breathe as easy as they can. It could be blowing the nose, right? Or suctioning the nose if they're younger, and that helps. Or sitting them up if they're laying down. Let them rest. If they're tired, they don't feel well, let them take a nap. And then, of course, that preventing infection, washing hands, making sure the glasses that we wash them or the sippy cups, whatever, making sure that we keep them as clean as possible. And the biggest thing we can do for a kid in pain or with a fever is to give them something. Little children, those young kids, they've got a fever, they stop playing, they stop eating, and they're just, poor little things look so miserable, right? Give them something for fever. The temperature comes down, they're up, running around, drinking like nothing happened. And then the fever goes back up. They stop eating, stop drinking, and sit in the corner. Now, with fever and with secretions, what is our thing we need to do? Well, we need to keep them hydrated, right? We want to replace the fluid that the fever is burning up. We also want to give fluid to loosen secretions so they can blow it out easier. So getting that temperature down is one of those high priorities. And it's not because it's dangerous. Fevers are not dangerous. It is when the fever goes from 98 to 101 in a very short amount of time. It could be 20 minutes, 30 minutes. And it's what we call the rate of rise. When it goes too quick, that's your febrile seizures. I've seen fevers 106. I've never seen a seizure in all of my career due to an elevated temperature. We give it to have them reduce the fever so they can eat, drink, play, and be somewhat normal. We don't do it for worrying about seizures, okay? So once the fever's down, they can eat, they can drink, and they feel better. So otitis media, what do we do for it? Well, we go get it seen by the doctor, and we always say it's going to be a bacterial. Staph is in our upper airways all the time. So we give them an antibiotic. Those antibiotics that the doctors need and we need to tell the parents they need to take all the doses and finish the course. Another thing is to have those ears checked after you've completed the antibiotics to make sure it's gone. You do have some resistant type of infection, so that's an important thing. Also, again, we want those liquids to get that liquid moving and draining out of there. And remember, ear infections are painful. So pain is also priority here. You don't really have big fevers with ear infections. It's more of pain. Kids come in, I've seen them in the ER, I can still see them coming in and just holding their ear and crying, giving them some, ibuprofen. It's got a little anti-inflammatory in there, right? And it works. And in 20, 30 minutes, the kid feels better. They don't want a hot pack on it. They don't want you to touch it, but get that little ibuprofen and they do a lot better. Another thing with ear infections, and I tell parents this, is when they go to bed at night, have them up on two pillows. Because when you lay down, those ears pull back. And guess what? It causes pain. So if you have them sitting up, they're not going to have less pain. Preventing reoccurrence, there's many things. And one of the big things is secondhand smoke in the house. That's the one thing that you hear all the time. Now, infectious mononucleosis is a virus. It's what we call herpes-like Epstein-Barr virus. And we don't treat it with antibiotics. We treat it with your antipyretics and rest and liquids, right? Just that's all we do. What you see with mono is they're tired, like extreme fatigue, fever, and you do have good fevers with this. Sore throat is a big one that keeps complaining. And then those aches and body pains, and you might have some swollen lymph glands anywhere in the body. And sometimes you might see a rash. Now, what do we do? And what happens? And the progression of events so that you remember. Infectious mononucleosis is actually very hard to diagnose. You go into the doctor, you have this sore throat, fever, and all the body ache stuff, and they do a culture and they do a strep test and probably a flu test at this point, COVID test, and everything's negative. They say, oh, you just have a viral pharyngitis. So Tylenol, Motrin, rest, fluids. Well, 3 days later, the kid's still sick. Go back to the doctor. They order an antibiotic. It doesn't work. 3 days later, they're usually at urgent care or at an ER. And then we hear the progression of antibiotics didn't work. They already did the test. Well, of course, they'll redo the strep, they'll redo the flu test, etc. And of course, they're negative. But at this time, we'll do take some blood. And in that blood, we're going to look at a CBC and we'll do what we call a monospot test. Now, the CBC, we're looking for the white count, right? We want to see if there's an infection. And with infections, you have elevated white counts. So we'll be checking that. It's usually fine. We'll do a monospot test and it will be positive. Now, what is the big deal about mononucleosis? It's a kissing disease. It's no big deal, right? Well, I told you we could have swollen lymph glands, but you can have swollen liver or a spleen. Usually it's the spleen that causes the problem. It gets big and round like a balloon. So you need to protect the abdomen because it can rupture. And we will tell them no sports, no PE, and you need to go to your doctor and get permission to go back into sports. Now, let me tell you a horrible story. 9-year-old boy came with his dad on a Saturday morning into the ER. What I said, they went to the doctor, it's a virus, got antibiotics. Kid's still sick, complaining. The kid comes back monospot positive. The doctor explains, be careful with the abdomen, no contact sports. You've got a swollen liver, spleen, whichever one it is, and you need to protect it. 1 week later, I am the primary trauma nurse. So any trauma that comes in, I'm the primary. I need to take care of it. It was that boy who was out in the Everglades on an ATV, fell off, fell on his abdomen, and his spleen ruptured. They took him on a copter, brought him in. He was dead on arrival. The spleen burst. I told him, and the doctor told him, and this child died. So mono is not as benign as we think it is. So just remember this story if you ever get a child with mono, to make sure they protect that belly. Even like me, I had 6 brothers at home. They can't wrestle with you and pick on you and roll around the floor, right? Because they used to always do that to me. So again, it is benign, but it can be extremely dangerous. Now, bronchitis is that dry, hacking, non-productive cough, and it's worse at night when you want to sleep and you're coughing, 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 coughing. It is usually a virus, okay? And we'll treat it with your antipyretics for either fever, pain, humidity. One of those little humidifiers there really work. And then, of course, cough suppressants. And that can help decrease the cough and try to let you sleep at night. It's one of the hardest things to try to sleep and you can't. Now, croup is a type of bronchitis, but it's a little more, and it affects the larynx and the trachea and the bronchus, and it gets swollen. And this is the seal coughing. This is that loud, distinctive barking cough. And what happens is your epiglottis gets a little swollen. So that's air going into your lungs. So it's swollen. You have to work hard at breathing in, okay? And then when you let it out, it is a bark. You can hear this, across the ER. You can hear, oh, that kid has croup. Now, if croup is not treated, the swelling of the epiglottis gets more, and then it becomes dangerous. So we'll go into that next. Acute laryngotracheal bronchitis is croup. It usually, again, is a virus. How do we treat it? We give some sort of dose of steroids to decrease the swelling of that larynx. It decreases, air can go in, inspiratory, now we can breathe. So this is the respiratory that's inspiratory stridor, okay? Because they pull in hard, you're going to see all of those things have to do with respiratory distress. You'll see inspiratory stridor, you'll see substernal retractions, and then you're going to see that barking, that cough. And if we don't treat it, you can see it'll go into respiratory acidosis, respiratory failure, and could turn into acute epiglottitis. Now, epiglottitis, that epiglottis is what? That leaf-like structure that covers the trachea when you swallow food. It's a useful thing, but if it's swollen, covering the larynx, how is air going in? Now, croup is a little swelling. Epiglottitis is almost the whole thing. It's like putting a hand over the top of the tube, trying to get air in, it doesn't work. So they're like, and they can't get air in. Now, what would you see? What would a child look like? Well, of course, they're a little hypoxic, so agitation is part of respiratory distress, right? They don't swallow, so they're drooling. These children don't cough anymore. And you will see these kids with a muffled sort of voice, like, and you know something's going on in the back of it. So we have an airway issue here. This child cannot breathe. And if we let it go on, the kid's going to die, right? So what do? Well, initially, the first thing we grab is usually an aerosol, which has racemic epi in it. So it goes directly down, and the epinephrine hits that epiglottis to try to decrease the swelling. At the same time, we're starting an IV, we're getting IV steroids in there, decrease it also, that swelling. And one of the things you need to have, and put it at bedside, even if the doctors haven't asked, you better get it, is an intubation tray or a tracheostomy setup. I've never seen it get to the point of needing a trach because I hear it, I see it, I'm running, and I'm getting my racemic epi right away. Somebody else getting the IV, and I'm getting my solumedrol steroid ready to go. But these kids go and what I call crash and burn really, really, really quick. So you have to get that airway open. And with all this swelling, and just like not just the initial point, it's going to be for a while. You need to maintain hydration. Some of the kids are mild epiglottitis and some are severe. So oral or IV depends on that. And that really mist of O2 in a mask is good. And as I said, nebulized epinephrine called racemic epi aerosol and steroids, and they use solumedrol most of the time. Now, when you have an infant, they get these respiratory illnesses called RSV, right? Respiratory syncytial virus. It's also called bronchiolitis. Those names are used interchangeably, so know that. RSV, bronchiolitis, same thing. It has to do with the bronchioles get swollen, they get irritated, and it creates a fever and it gets a cough and difficulty breathing. Now, these are your infants. And usually when they're most affected the worst are the younger kids, like under 6 months. Now, that normally with a normal, healthy newborn and every other way infant, it's not a problem. But what if you're a cardiac child? What if you have cystic fibrosis? What if you have something that decreases your immune system and you can't fight? And that extra work of breathing could be dangerous. we need to do something to prevent it, right? So there is a monthly immunization called Synagist or palivizumab, and that mab is an antiviral, okay? So monthly. So once a month, usually it's, if you're from the cold weather areas, it is like November to April. So winter to early spring. In Miami, it's a little bit different where I'm from, but it's the first year only. After that, we don't use these immunizations because at that point, the kid's old enough and can tolerate the secretions. Tonsillectomies. How many of you have children who needed to have tonsillectomy and adenoids of their children taken out? Oh, and tubes at the same time. It is that child who has those tonsils and they're always getting inflamed because everything's in the mouth, right? So they're always infected, et cetera, et cetera. Now, what do we need to do post-operatively for these children? Now, post-operatively, they've got this area, and what they do is they cut the tissue and cauterize it, and it creates these big scabs in the back of the throat. All right, so with that in mind, and then the adenoids, that would do it also. Tubes actually isn't a big deal, it's the other stuff. Avoid irritating high season food. It's going to burn. Orange juice. Oh my goodness, burn. You're not going to do anything vigorous, whether it's brushing the teeth, gargling, you're not. Because if you do, those scabs can come off. And I'm telling you, they can bleed out. I've seen one child almost completely lose half of her blood in her body from puking blood with big clots in it 7 days post-operatively. So again, we don't want to go in there and anything in the back of the throat. We got to keep it calm, as in also avoiding coughing. Don't put clearing the throat, clear the throat like that can cause it. And of course, nothing in the mouth, no straws, because it puts a lot of pressure back there. So it does hurt. I had a tonsillectomy at age 21. So it does hurt. So some sort of analgesic. With children, acetaminophen, Tylenol is all they need. And then younger kids don't like it, but an ice collar on the neck actually helps with pain too. The older kids will, but younger kids don't want any part of it. Oh, it's too cold. Get it off of me. When they have this tonsillectomy, they need to be quieter. They can't be running around. They need to relax and watch movies and use their tablets, right? They don't need to be doing those things. Now, older kids who have the ability to chew gum, they need to chew gum. And why do we do that? Well, ever go up in a plane and your ears pop and you're chewing gum and it helps it pop? Well, it's the same concept with tonsillectomies because the ears get full and they hurt. So chewing gum actually helps with the ear pain of it, okay? Now, what should we be worried about? Like how long do we need to be, relaxing and not letting this kid run around, etc.? Well, usually 1 to 2 weeks after surgery, they can move around more. What would you see if there was problems? Well, you would smell their mouth, and it's a horrible, rotten type of smell. They've got these big scabs back there, and they just like a scab on your knee when you fall that's juicy. Well, it's the same thing in the back of the throat. If you see a fever, and usually it is about 5 to 10 days post-op that these things and infections do occur. If they have that ear pain, it's really, really bad, or they are starting to cough, these are things that they need to go to the doctor. The girl I was talking about that almost, bled out her blood, she was 1 week post-op. She went to the ENT. They just checked her and just cleared her for activity. And on the way home, she vomited in the car and it was blood. So they brought her immediately into the ER, and I took one of those pink buckets, the wash basins, and she filled up half of it with blood and clots like the size of a baseball. what I did was I actually picked her up, ran her into the trauma room, yelled for the doctor, yelled for somebody to help. Let's get an IV in. And this little, I think she was 7. I gave her 1,000 mLs of normal saline. Her heart rate was 180. Her blood pressure was 70/40. She was in hemovolemic shock. And we took her back right away and got it up. And they had to take her to the OR and recauterize that area. So a tonsillectomy, it is a big deal, right? Pneumonias, different types. We could have it where you have aspiration pneumonias, things that you inhale. You know, ever clean the bathtub and you have these caustic chemicals that you're doing it and you inhale it, it can burn the lungs. That's part of it. But pneumonias are your lungs, your lower lungs. It can be bacterial, viral, like I said. There's one called mycoplasmal and pneumococcal, and we now have that vaccine, which they do get at a younger age. Pertussis, we give an immunization for that, right? So why are we discussing it? Well, there are some children who do not get immunizations because the parents are, well, for whatever reason, religious reason, they just don't. They don't immunize their children. Pertussis is extremely contagious. It's airborne. And these children, if we suspect pertussis, again, just like we're talking about children with chickenpox, put a mask on you and get them into a reverse flow and protect those other children in, whichever, in the ER, on the floor, or whatever you're doing with those kids. We just had a case burst out with 5 kids in the county above me. So it's still there, as much as we'd say we don't want it. And here's the quarter. Here's my little grandson. Decides to put a quarter in his mouth, starts wrestling with his mom, and it went down. This happened. It's, something, it's always the quarter. It's never a dime or a nickel or a penny. It's always the biggest coins that they have in their mouth. I've seen beads, backs of earrings in noses, in ears. I've seen them swallow them. I actually saw one kid who swallowed a French fry. He was at the country club with his grandma, and he was sitting there. He was 3, having a French fry, and he aspirated it. And it went into his lungs and it blocked his airway. And he had to come in by rescue. And he actually ended up being needed to be put on ECMO, which is the machine that pulls blood off, oxygenates it, and puts it back in. It's like a heart lung machine. And the kid didn't do well from a French fry. So, I mean, foreign body aspirations, they happen. I mean, my grandson, it hurt. My daughter in law called me right away. I said, it should pass. If you have increased pain, get to the, emergency treatment. I said, but if not, just be checking the stool, make sure it comes. Because the first thing they'll do is take a picture. Where is it? Is it blocking the airway? Are they alert? Are they breathing? So those are things we worry about with any foreign body. Are we breathing? Some of the aspirations, baby powder, used to be a thing that we used to love putting on our kids in a younger age. Johnson's baby powder, the smell was great, but the powder in the air, they aspirate it and can hurt their lungs. Also, remember when you feed aspirations, all ages, they can aspirate. So, with infants, children, making sure, especially your younger ones, making sure they're burped well, making sure they're sitting up after they eat so that it has a chance to go. And that can help with, those aspirations. I think a lot of these aspiration pneumonias are those kids with reflux, with GERD. Cystic fibrosis. Usually, this is something, a lot of time it's familiar. It's somewhere in the family that makes you look for it. Sometimes it's not. This is another one of those at birth, you are going to see them constipated, no stools in the first 2 days of life on an infant. This is one of the things they test for cystic fibrosis. And then you heard me earlier talking about your thyroid, low thyroid. So cystic fibrosis is inherited. And once we diagnose this, what do we need to do? Well, it affects two things. It clogs the lungs up with mucus, and it's like a petri dish ready for bacteria to grow in there. So you need aggressive pulmonary toileting, pulmonary care. The other thing is the small intestines and the digestion of food cannot be done. And one of the things you see is that greasy, foamy sort of stools that come out, part of it, because it's undigested food. Now, I've always, told the students, you get a kid who that you think maybe is cystic fibrosis because of history, and the mother wants to know. I'd say, well, lick your infant's skin. You will taste like salt, like sprinkled on the skin salt in their sweat. It is a lot. I used to say, go ahead and lick the kid, but we as nurses aren't going to lick one of our infants, one of our patients. We won't do that, but we could tell a parent to do it. So salty skin, you're losing salt like crazy. So you need to keep salt in the diet, right? Because the lungs are bad. They're coughing and we're like frequent lung infections. And of course, with all this mucus that's occupying space, wheezing, shortness of breath, because of the inability to digest food and the pancreas, you're going to have those foul, smelling, greasy stools. And you will, once you smell one, you'll never forget it. And because we are not absorbing the food that we need, they're not getting the nutrition. These children don't gain weight. And remember, no nutrition, it's also cognitive problems. So we have to be very aware of nutrition, gaining weight, and making sure cognitively that they're there and that they are gaining weight. So diagnosing a cystic fibrosis is you get the symptoms. As a newborn, it's constipation. It's the first thing we'll see, just like your hypothyroidism. So, but what we do for cystic fibrosis is we do a sweat test. And it's just a probe that we put on there, and it measures the salt, the chloride in the sweat, and then you're diagnosed. Now, treatment. Well, you have those infections in the lungs, antibiotics, right? Your lungs are full of junk. You're doing different medications, your albuterol. You're doing sometimes even aerosolized antibiotics. Gentamicin is a big one they like to put in the little cups for the inhaled aerosols. It does work. And of course, chest physiotherapy. These are the kids that have those vests on that go and they sit there morning and night and get these done. And they're not just on, just an albuterol. They're on all different sort of, things to keep those lungs open. Another thing is besides those lungs keeping them going, we have that problem with the small intestines and the absorption of nutrition. So we give medicine to replace those pancreatic enzymes that aren't working or they don't have. And it's usually called pancreatase is the name of it. Now, these come in a capsule, and inside are little tiny enteric beads. Now, this is something that we should take if they're older, they can swallow it, and it's immediately before they eat or have a snack. They don't take it, they're not going to absorb their nutrition. Again, those beads, enteric coated, we know we never chew those, right? We can't crush them, chew them. But sometimes younger kids will put it in a little bit of food and give it to them. This is the only time I would say with medications, you could put it in food. I would put it on like a little teaspoon and then get the whole teaspoon in there in the beginning before we eat the rest of it. There are some powdered forms, and it can damage the teeth. So you should rinse the mouth after they eat or after they take it. And one of the things I think that's the hardest in peds is to remember to increase the dose as they gain weight. In 1 year, they could gain 10 pounds and they didn't increase the amount of pancreatase, they're not going to get their nutrition. So making sure that we do that. Now, As children get older, they become adults and they want to have children, right? Women can get pregnant more than men. Men, what happens is the vas deferens is all full of secretions, and they're not giving the mother, the mom, their sperm with live sperm in there. It doesn't produce; it's blocked. So they're just blanks. There's nothing there to get a baby for the moms. But so women are okay. Of course, it's a high risk pregnancy, but men will have to go to a bilateral lung transplant. And then 1 year later, the secretions are less. They're able to have sperm and they can get their wife, their significant other pregnant. So that is cystic fibrosis. Acute respiratory distress syndrome is when the lungs are damaged somehow, some way. Could be a drowning, right? You go under the water, your lungs fill up, and there's no oxygen being delivered to the body. Overwhelming sepsis, probably the biggest thing that causes problems in children is infection, sepsis. How about trauma, being run over by a car, which I'm telling you, I've seen, and then drug overdose. Those are usually your adolescents. Probably your sickest kid you'll ever see is a respiratory distress syndrome. Mortality rates are extremely high. This picture that you're seeing right here of all of that, that is what we call ECMO. It's usually it's into the neck of a newborn, and they pull blood out, goes through a machine, it gives it oxygen, and it puts it back into the body. It's doesn't nothing to do with heart or cardiac output. It's just to get oxygen to the child and to the organs and to their brains, okay? I actually had to do special training to be able to run that machine, and I did do it. It's very, very interesting. But I'm one of those adrenaline junkies. I like to understand and know things. Acute respiratory distress syndrome, the kids are sick. And sometimes you have two nurses to one child. That's how sick they can be. So we've been having some questions about CPR. I want you to make sure that you go back and look at your CPR, the two breaths, 30s, compressions, knowing those things. What happens if there's something blocked in the airway, how to do abdominal thrust or back pats, or what do you do? Heimlich maneuvers, those things. The other thing we need to remember is the parents. Can you imagine being a parent and your child is going through CPR? And they're a lot of times no matter what age, right? I try to keep the family with the child. Years ago we didn't. We threw them out immediately. And then the parents like, "Oh my God, and what if the kid dies? That parent wasn't there." So we've realized that, it's better to have them there if at least they're holding their hand, and they can see that we're doing everything we can. But if it's that case where we can't have them there, depending on what we're doing, make sure somebody is with that parent, okay? Because they need that support. They need those updates. They need to know, what's going on. Now, asthma, most common of all the children's airway issues, right? How many of you have asthma? How many of your children? How many people carry around their little meter dose inhaler, right? Well, asthma is some sort of inflammatory disorder, and it creates this hyper responsiveness and creates this cough and expiratory wheezing. Okay, remember, croup, it can't get in. Asthma's lower, the bronchial swell, so air goes in and it gets stuck. And now it can't get out, so it's expiratory. Those are two concepts you need to remember. So how do we diagnose it? How do we know what's going on? Well, those children with chronic problems with cough and wheezing is something that we're going to investigate. And we'll do pulmonary function tests when they are healthy, not when they're, in an asthma moment or attack, if you want to call it. They're going to be checking, what are you allergic to? Is it cats? Is it dogs? Is it the grass? Is it foods? And if we can eliminate that, we'll decrease the amount of times that these children have these attacks. I mean, our goal is to keep these children being children, which would mean maybe having their little inhaler with them, maybe taking, some before they go out and to start to play to give them maximum breathing, right? And always we want to prevent any sort of exacerbations. We don't want them to go into one of these attacks. We give long-term medicines, things like in adults, you might see Advair, Brio, Symbicort. In children, it's something we call Pulmicort. And it's a little bit of steroid in an inhale, and it prevents attacks, okay? And then we have the little albuterol, and you can give this little child here. It's a great picture. It tells it all. He's got a meter-dosed inhaler stuck in the back of this plastic tube called a spacer, and then he puts it around his face. And if we hold it there and give the dose, usually 2 squirts, he inhales in and out 3 or 4 times, he's gotten the dose. In some children, they cry when you do that. Guess what? They're taking big in breaths in, so they're getting their dose really well. So it works good. If they're having some sort of asthma attack, one of the treatments is steroids, corticosteroids, and that helps. Okay, let's go into the heart. Now, I want you to think of a heart as a garden hose and know how blood flows through the body. So let's trace a drop of blood. So we know blood starts the last where it goes. I'm going to start where it last goes and go back to there. So it just gets back to the heart and from the vena cava and goes into the right atrium. It goes through the valve called the tricuspid valve, and it goes into the right ventricle. Then it goes up through the pulmonary valve into the lungs, gets oxygenated, comes back to the heart through the pulmonary vein, and it goes into the left atrium. It goes through the mitral valve into the left ventricle, goes up the aortic valve, through the aortic arch, through the aorta to the body, all over the place. And then that last little bit, again, comes up the right side into the heart. Anywhere you kink it, it's going to go backwards. And that's the way I want you to think, because that will help you understand a lot more. So in children, usually when you talk about cardiac problems, it's usually a congenital defect. They're born with it, there's nothing they could have done. It's just what it is. Sometimes there's history in the family, sometimes there's not. And then there's the acquired. Usually in children, it's usually 2 ways it's acquired. An infection, which is usually viral. It causes the heart to it's a viral cardiomyopathy. The heart gets big and floppy. The muscle doesn't work well due to a virus. And then the other one is autoimmune response, like lupus, right? It can attack the heart and the heart muscle. So that could create problems. All right. That's your heart. And that's the blood. And that's the way it goes. Let me give you something with this picture because you have a visual of the blood flow. What would happen if when the blood leaves the heart, goes up over that aortic arch, and what if that hose, that aortic arch, there's a pinch, there's a narrowing, there's a kink in the hose. what do you think would happen? What would you see? Well, blood's not going to go down as strong as it would if there was no kink, right? So lower extremities, you may not feel a posterior tibial or a dorsalis medial pulse, or you might have cold feet, right? Because it's not going down. Your blood pressure down there, there's no blood flow, so it's going to be lower in the legs than it is up in the arms because blood's not going there. Well, I just said blood's not going down, but the heart's still pumping. So where's the blood going? Well, it goes back into the left ventricle. Well, when that's stretched up enough, it goes up to the left atrium. And when that's stretched enough, it goes back into the lungs. So what would you see? A congestive failure, lungs full of fluid. Now you're going to see difficulty breathing, tachypnea, dyspnea, you hear rhonchi, rales, really severe respiratory distress. That is, heart failure. The name of that condition is called coarctation of the aorta. So did you see the blood flow and how the below is less and then the upper is going to be higher? So sometimes this condition is not noticed till later on. They could be 2 or 3 years old. And usually the symptoms you'll see is you have a lot of blood still going to the upper extremities. If you see those 3 little vessels that go off the top of the aorta, it goes up into the head, right? The carotids. You might have headaches. You might also have nosebleeds. And those are the 2 things that you would see in coarctation of the aorta in the older child. So coarctation, all they do is it's a surgical procedure. They just do a thoracotomy and they go in, no, they do the heart, and what they do is they either take out the piece or they try to open it. Sometimes they'll do a cardiac cath, but usually it is a surgical open heart procedure. All right, let's look at a heart. Let's look at what you would see. What would you see in a child that's having cardiac problems? Let me turn her off.
Thirsty.
All right, so let's take that coarctation of the aorta. In fact, probably one of the most common ones that you see come back later on, that's sometimes not caught at birth. One girl of mine came back at 3 months, and what did I see? Exactly this. She wasn't eating. She was tachypnic, tachycardic, and because her heart's working so hard, beating against these things, body's not being perfused with blood, the heart beats faster, and burning all the calories, failure to thrive, and poor weight gain. Just feeding is a big thing, and they would even tuck her out and stop feeding because they're just have no energy. Well, lack of oxygen, bad nutrition, cognitive delays, right? Makes sense there. And, sometimes again, you might see positive prenatal family histories, but sometimes you don't. So, what's a little nursing diagnosis? Inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed, right? If they have no energy, they have no oxygen, they're not going to feed, they're going to not gain weight. What do we look at? Well, it's easy when the kid is blue. That's the easy thing to see. But coarctation is an oxygen. It is there. So you're not going to see this bluish cyanotic discoloring. In other children, nutrition, yes, older kids you'd see, but at birth, you don't see any nutritional problems. A lot of times you'll see the chest, you'll see it, with deformities, whether it's concave or convex. A lot of times you can feel your hand on some cardiac problems. Put your hand on the chest and you can feel like bzz, bzz. And sometimes those are your big holes in the heart, your septal defects, whether between the atrium or between the ventricle. In fact, that's the first thing I do is put my hand on the chest as I'm looking at these kids, and I can just with that say, "Ooh, that happens to be probably a big ventricular septal defect." Of course, respiratory, you'll always see problems if they're looking for oxygen. And as they get older, that's where you see the clubbing. And I got some pictures later on of that. So how do we go ahead and we look at these things? Well, you're going to look at the chest, look at the abdomen or the abdominal breathing, checking for pulses. I actually did catch one coarctation of the aorta when I was very, very young into the newborn ICU, one of my first year, I think, into it. And I was feeling for pulses in the feet and I didn't feel any. And then they went and did the echo and they found it. So nurses find these things when doctors don't. So peripheral pulses, just as simple looking at the heart rate and rhythm and the sounds, you can see a lot there. First thing we do is put them on an EKG, right? And look at it. And then we do, of course, the 12-lead EKG. Once we see a problem, we're going to go ahead and do an echocardiogram, which is an ultrasound of the heart like you do when you're having a baby, but it's of the heart. And they look at blood flow and they can see all things. If they see anything that's abnormal, this child will be going for a cardiac catheterization. They want to find out exactly what's going on and make a plan for these children. And then there is actually a cardiac catheterization called interventional, um, where they can close up VSDs, ventricular septal defects, ASD. They can balloon valves that are too tight. They could the coarctation, etc. Interventional. And then the other one that we see is what we call electrophysiology studies. I call them EP studies. These are usually those children and adults that can all of a sudden their heart rate goes from normal to 240. It's like, and then it goes normal. And these children, of course, are placed on some sort of beta blocker, try to slow down the heart. But there's a way to go into the heart. Where does your heartbeat originate from? If you remember cardiac, isn't that the thing called the SA node? That's the pacemaker of the heart. And according to the age of children and adults, you'll know what's too fast and too slow because that's where the pacemaker is. Well, what happens when the heart has these irregular beats where it goes too fast and then it goes normal again? Somewhere else in that right atrium says, hey, I want to take over the heartbeat for a while. So it's a different place. It's not where it should be. And all of a sudden, they start firing and make the heart rate go crazy. Well, they can make this occur during a cardiac cath, and they take a laser and they laser it. And they say, you're not doing that again. And they're gone. And it does take care of those elevated heart rates. Let's go to an EP study. I worked also in cardiac cath. So when you're going to have a cardiac cath done, I said anybody with an echo that's showing problems is definitely going to go for a cardiac cath. So pre-procedure is basically NPO, and newborns, they'll feed up to 2 hours prior to because they were worried about hypoglycemia. Now, when this kid comes back from a cardiac cath, they've had in the cardiac cath 2 big catheters, IV catheters, into the right groin, in the right femoral vein and right femoral artery. Okay. When they're done, they pull them out, and the nurse holds that area for could be 2 minutes, 5 minutes, 20 minutes until it stops bleeding. And then they put a pressure bandage on there. Older kids will get a sandbag of whatever size, 2, 5 pounds, whatever it is. Put it on there to keep pressure there. All right, so the blood is stopped. They've got the pressure drip bandage on there, and they're going back to the room to bring your child. Well, they're in us on a stretcher. and they have to be moved to bed, or they're in their, isolates and they're bouncing around, going down the hall, and the possibility of that little area, which is, stop bleeding, can pop off and start hemorrhaging. The size of these catheters are huge, okay? So they can bleed out so quickly. So the biggest thing, most important priority, first thing I do, I check that dressing. Can you imagine an infant who's just pumping blood out quickly can lose their whole blood volume very quickly? So you check that dressing for oozing and bleeding, because the biggest risk of anything here is hemorrhage, not infections, not allergies, none of that. It's bleeding out, okay? Once I check that dressing and I'm okay, I'm going to be checking the pulses and the feet. Always, the right foot's going to be slightly decreased. Make sure you document that well so that the next nurse knows what it looked like. It's slightly decreased, but it's present. Capillary refill is, okay? Then we want to make sure what fluid, because they need fluid, whether IV or PO. If they have an IV, make sure they're getting fluids until we get something by mouth. And then we always check a blood glucose level, especially your younger infants. They don't run glucose as normal mainstay in a cath lab. It's usually normal saline. So they're without sugar for a while. So making sure that we check them, because blood glucoses could be 20. And I've seen that. And we don't want the infant because it could cause problems with the brain, but not too much sugar. So congenital heart disease, there's more than you ever thought. When I just started working in the cardiac area at the hospital down here, I was surprised at the amount of children and infants that were there and the types of defects that they did have. It is the major cause of death in the first year of life after prematurity. The most common is that hole between the septum, between the ventricles. And that's when you listen to the heart and hear, instead of chiku, 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 you hear a big, and that's that vibration I was talking to you about. And as I said earlier, last week about Down's children, most common thing that these children have are cardiac defects, and the most common is the VSD. Now, you need to know, like, as I said, coarctation, they're still getting blood, so they're acyanotic. There are other ones that blood's not going to the lungs or can't come back from the lungs, and they have extremely low O2 saturations, if none. And we're going to go into some of them, okay? So, cyanotic or acyanotic. Do they have oxygen? Are they getting from their lungs or not? And then the other thing is shunting. Like I said about the ears, you have all this mucus here. The area of least resistance is where the mucus goes up into the ears. Same thing when you talk about the heart. If you look at the heart, the last bit of blood just gets to the right side, right? And that left side has all that blood flowing from the lungs, so pressures are higher. So if there was a hole between the left side and the right side, whether it be in the atrium septal or the ventricular septal area, it's going to go from the left to the right. Do you see that? Because there it goes. There are questions you'll hear about. If you had an atrial septal or a ventricular septal defect, what would you see? And what you would see is an increased pulmonary blood flow because it has to go back in there again. It's like double dipping, right? It's gone to the lungs, come back to the right side, and back up into the lungs, okay? Now, these are your diagnoses and what you need to know about. And like I just said, atrial septal defect, ventricular septal defect, because it has to goes from the left side, the shunt pushes it back over, you're going to have that increased pulmonary blood flow. I mean, it's okay. but it's just extra work that doesn't need to be done. There's another thing called a patent ductus arteriosus. You ever, some of you haven't taken maternity yet or in the process. So PDA is fetal circulation. And in utero, there is a connection between the lungs and the body with a tube called a ductus arteriosus. And it connects the pulmonary artery to the aorta. So pulmonary artery is lungs, aorta is to the body, and it's open. And it allows blood to go from the lungs to the body. And some of it goes back because of that pressure thing. But patent ductus arteriosus is something you're born with. But right after birth, it starts to close because mommy makes this hormone called prostaglandins that keeps it open. Well, mommy goes and is gone, so it can't keep it open, so it closes. But I'll go into when it doesn't close and what we're going to do. Obstruction of blood flow. I've already told you about coarctation, haven't I? So you know that one. Well, what if the pulmonic valve or the aortic valve were tiny? Now, osis means it's narrowed, okay? There's still a little bit of flow that can go there, but it's decreased. Atresia, A is without. So tricuspid atresia means no blood is going from what? Tricuspid atresia is the right atrium and right ventricle. It doesn't go. There's nothing there. So blood's not going to the lungs. So that is a scary diagnosis. Cyanotic, you can see why, not going to lungs. Now, this what we call mixed flow. What the one that you need to understand is transposition of the great arteries. And this is when they're switched. The pulmonary artery and the aorta are switched so that blood goes to the lungs and stays there and goes to the body, stays there, and there's no mixing. There's no oxygenation going on there. That's when you need that PDA to keep blood flowing. And we do use that to keep these children alive. And I'll go into it some more. And the other thing that's probably the most of all the diagnoses is the one that creates more care is hypoplastic left heart syndrome. Well, the left ventricle is your engine, right? It pumps blood to the body, that muscle. It's hypoplastic, that muscle, which means it's floppy, it's thickened, it doesn't work, it doesn't pump blood. And these children need a minimum of 3-stage surgeries, and many of them end up with a transplant. So, PDA. PDA is at birth, that good old prostaglandin keeps it open. And what it does, it allows oxygen to go from the lungs to the body. That's why in transposition, where there's no oxygen going anywhere, it keeps oxygen in the body. Now, sometimes, especially I've seen it in your premature infants, they have this and it doesn't close. Mommy's gone, the prostaglandin isn't there, but it's still wide open. How would you know that? Well, if you listen to this heart, there's like a washing machine murmur. It's pretty loud. It's not a, it's, it's like really loud instead of chikoom, chikoom, chikoom. There's different sounds. Usually the way that I tell it, besides even looking, is usually these children have some sort of arterial line in the umbilicus line, and it's an arterial blood pressure. And the thing is, the numbers are really distant from each other because an infant, a neonate at birth, has a normal blood pressure of 60/40. An infant born with a PDA that's not closing will have what we call a wide pulse pressure. That means that bottom number is really low, okay? What's neat is watching it as we treat it and watching that number come back to normal. And we can I mean, you can listen to it, but I like watching the blood pressure. So as I said, some of children need that PDA open. And sometimes when we need it, we know that's when the body wants to close it, right? They don't have prostaglandins there. So what do? Is we give a slow, continuous infusion of a synthetic prostaglandin. And what it does, it keeps that PDA open, all right? And it maintains the heart and it maintains oxygen. So this would be used like for that transposition of the great arteries or that tricuspid atresia where no oxygen, no blood's getting up to the lungs for oxygen, okay? Now, sometimes this PDA isn't needed for any reason, and we want to close it. And somehow prostaglandins is where they keep it from, where they get it from. It's not known, but medically, we could give a medicine called indomethacin, and it's actually an NSAID. Years ago, this was used for back pain a lot, like an ibuprofen. It's called indomethacin. It's IV. It's a 3-dose thing that we give. And as I said, as we're giving it, you can watch the blood pressure and you can watch that diastolic number go back to normal and it's closed. Sometimes it doesn't work. And this is the one you need a thoracotomy and they put a staple on it. And that's all they do and close it. So patent ductus arteriosus. I'm going to show you these things. They're here for you to look at, but I've discussed them. Blood flow. How does way things go? But I really talked about them. Congestive heart failure, just like adults. The heart, it doesn't have the ability in order for it to pump the way it should. And what happens is blood accumulates in the lungs, and now you can't breathe. You have all sorts of respiratory issues. And, besides that, it's all about nutrition and being tired and weight gain. And so we need to correct this. It could be on the right side or left side, doesn't matter. It just means the heart's not working the way it should. You're going to see a kid full of fluids, and that's just a picture completely full of fluids there. So what is our goal? What do we want to do? Well, we want the heart to be as well as it can. And we need to get rid of that fluid. These kids are put on furosemide. These kids are put on digoxin. Again, mics per kilo, milligrams per kilogram doses, just like adults, same thing. And you get rid of the fluid, we get that digoxin, which makes the heart beat stronger and slower. And now we've had better perfusion. Well, what are some things we do to measure it? Daily weight, strict intake output. If they're getting rid of fluids, we want to see it. How much is coming out? And that's how we monitor the progression of congestive failure. Remember, if we give digoxin, it's just like adults. You have to count the apical for 1 minute. Check the electrolytes. You need a potassium that is normal. Check the digoxin level. We don't want digitoxicity. And how are you going to measure digitoxicity at home? How are you going to teach a parent when you're not doing these blood levels, haven't have one? Well, with infants, one of the things that you'll see is vomiting for no other reason, because vomiting is a side effect of digitoxicity, right? So you would tell that parent, if this child is vomiting, call the doctor, and the doctor will probably say, let's go do a digoxin level, and you're going to hold that digoxin. Better to hold it than give too much. We want to make sure that the body's perfusing, we've got good pulses, we want to make sure those lungs are getting clearer, we want to keep that nutritional status. We might put an OG, an oral gastric tube in, or a nasal gastric tube for feedings just to let them rest when their heart and their lungs are working so hard. And then again, if this kid's in congestive failure, teaching the parents what you see, right? So this is a clubbing. This is an older girl, and you'll see that clubbing. And that's a prolonged, probably a hypoplastic left heart child. You'll see those things. One of the things with the body is with these cyanotic heart diseases, the body tries to make up for it, tries to fix it. And what they do is the body will produce red blood cells. Because what does a red blood cell do? It carries oxygen, right? So let me make some more blood cells because that will carry the oxygen. Well, you still don't have oxygen because that's a cyanotic heart disease. So you'll see what we call polycythemia. These children could have a hemoglobin and hematocrit of 18 and 54, 19, 57, not uncommon at all. Their blood is so black and red and thick because of so many cells, because the body's trying so hard. Okay? So polycythemia is the body's trying, but the oxygen just is not there. To have a kid who has a congenital heart defect that's going to have long-term care is a lot for a family to undertake. So again, teaching them everything you're seeing and looking for, letting them know. I have found out cardiac parents are the nicest and the most thirsty to understand the information to take care of their kids. Let them know what's going on. Again, always preparing the child, the mother, father, whoever, and then how to take care of those kids at home, always preparing for the discharge. I've already gone over cardiac cath, and here's just another thing about it. What to do post-operatively. Remember, dressing is always number one. Bacterial endocarditis, an infection, staph or strep, even fungus, could be there. Again, this is somebody who will going to have prophylaxis before any procedure. Usually dental is what we think about. If this kid's going for cardiac cath, yeah, they'll get it too. Now, rheumatic fever. Rheumatic fever, rheumatic heart disease is a thing that can happen that they're going to be needing antibiotics. This is usually due to a streptococcal infection that the parents didn't treat it completely. It could be that they didn't treat it, or they didn't finish the antibiotic, or they didn't take all the doses. And now the strep is now affected the heart and other things with this. You're going to see joint, skin, brain, and the heart all changes, and something called chorea. This is those weird movements, and it's usually when you see the rash and you start seeing that sore throat still continuing, and then swollen joints going on. They usually bring them to the doctor, and usually the first question, so has your child been sick lately with a throat problem? And they could have had a little, quote, pharyngitis that was never treated, or they didn't go to the doctor, right? And this can cause it. The problem with rheumatic fever, everything can be corrected, but this will hit your mitral valve and it can damage it. Once this damage is damaged, the correcting and giving long-term antibiotics is not going to correct that, okay? So the valve, if it's damaged, it's permanent. Everything else can be, corrected. Those movements, the rashes, the joints, etc. All of that will be fine. Kids do get high cholesterol. It's a new thing that we're starting to look at. So again, with cholesterol, it's diet, to start with first, and from there they'll add medicines, but usually diet, we can correct it easy. Children have all sort of dysrhythmias, just like adults, slow, fast, or irregular heartbeats. Again, we treat with the same medications as adults. but in pediatric doses. Pulmonary artery hypertension is when the lungs, all of a sudden the bronchioles and alveoli get toughened and stiff, and now they're not allowing exchange for oxygen and carbon dioxide. So these kids aren't getting the oxygen the way they need. So one of the three things you see with this is they'll be short of breath, but with these stiffened arterioles, they don't exchange. So they're going to have difficulty with breathing, especially on even minimal exertion. That chest pain because they're trying to breathe and can't, and syncope, they don't have oxygen. I've seen children get transplants for this. I've seen children get placed on oral medications, and I've also seen them having their own, like an insulin pump type thing, but with medication for their pulmonary artery hypertension, which causes the dilatation. And they started using Viagra in some of these infants and younger children, and it causes dilatation of those things so we could breathe. I mentioned cardiomyopathy, cardiomyopathy, which is a big floppy muscle heart. It doesn't work. As I said, it could be due to anything, but viral infection is always number one, and that metabolic, it could be the lupus type things, and then there's collagen diseases that can cause it too. With cardiomyopathy, they usually routinely come in for what we call a tune-up, where we put them on IV medications to let their heart rest to get it in good functioning, but usually ends up they'll need a transplant. The biggest thing and the problem with transplant is rejection. It's not infection that causes problems, it's rejection, okay? Now, postoperatively, every kid who has open heart surgery is going to get a chest tube. Could be 1, 2, 3, 4, 5. Could be as many as it needs. All right. And these children, when they stop draining, are going to have those tubes removed. And I have worked in the adult cardiac post surgery unit, and I've worked in children cardiac surgical unit post op. Now, I have been told by adults that the burn when you pull it out is intense. It hurts, but it's only lasts for a little bit and then they're okay. So, that being said, what do you think is priority before taking out these chest tubes? Medicate for pain. Please give them a good dose of something. Please explain to that child. It's going to hurt a little bit, but it will be gone really quick. I'm going to hold your hand. Let's count to 20 together. All right? Gives them a distraction of something else to think about because it burns, okay? Take the vital signs before because you're given morphine, and do it after because you gave them morphine, and to see how they're tolerating it, okay? So, chest tubes, they do create pain, and always be honest with the kid. Don't tell them it's not going to hurt because it will hurt. We never did blood pressures on younger kids, and now we are. We found out there are younger kids with hypertension, and just like adults, if you don't treat the high blood pressure, you're going to have problems with many things, including your kidneys, your eyes, everything, right? Hypertension cannot be untreated. So we are now doing them ages 3 and up, where we didn't before. Now, Kawasaki disease is one of those things that I used to love to try to figure out and diagnose on the kids in the ER. It's pretty hard. Kawasaki disease is what we call an acute systemic vascularitis. Oh, what does that mean? That means the vessels get inflamed, blood vessels. And the ones we're worried about is the coronary arteries. They get inflamed. And when they get inflamed, they have little microembolus. They also can get aneurysms and burst, and that will be the end of the child. So Kawasaki disease, it's younger kids, younger than 5. And these pictures show you all the symptoms that could be. If they have those big red eyes, oh, it's just so, and it's glow in the dark, you'll never forget. You see a Kawasaki pink eyes, you're gonna know. There's no secretions, it's just red, glow in the dark red. They're quite distinctive. They also have a strawberry tongue. They have cracked lips, but sometimes you don't see that yet. You just see a little bit of peeling of skin on the palms of the hands and soles of the feet. And it is a virus. So these kids have been sick. Little bit of, I've been to the doctor, it's a virus, Tylenol, Motrin, and they're not doing well. So finally they come, they usually call infection control down to diagnosis because it's that difficult. And what we do is we admit them and we put them on intravenous gamma globulins, IVIG. It boosts the immune system. And this is the time we give aspirin. We're not worried about Ray's disease with this one. All right. We give high dose aspirin. Why would you give aspirin to a child with Kawasaki disease? Microembolus, right? We want to prevent clots and keep the blood flowing. Also, aspirin is an NSAID. It helps with fevers, et cetera, right? Shock. Most common is septic shock. I've said it before, I'll say it again. There's all types. Kids get infections and they go down the tubes very quickly. So it's knowing those subtle things. In your prematures, it could be apneas and bradycardias. That's what you see, premature. So surgical closure of that patent ductus arteriosus would do what? Well, let's go back and look at that. Where is that PDA? Connects the aorta to the pulmonary artery. So we got oxygen going, right? So if we clamp that off, what are you going to do? You're going to prevent the return of oxygenated blood back to the lungs and keep it out to the body. So that's heart, that's lungs, a lot of stuff. Did I explain it in a way that you got a little bit of it? It's pretty rough. All right, let's go do our cahoots, get that done. And then we'll be done. Where did you go? Lori, your screen is black. If you could get your face showing, that would be good.
She's trying to fix it. She's at my house. We're sharing my internet, and she got kicked off once.
Okay.
So she
No,
sent you an
that's
email,
fine.
but she got kicked off and then was able to get back on.
I can't see an email and teach at the same time, but thank you
Yeah,
so much.
no, that's fine.
I
We're just
thought
letting
I
you know.
saw something, so thank you so much. I get it. I was teaching on Friday night, just about to start an exam, and I got kicked off. So I know how it feels. It's like, oh, are you kidding me? Just ready to say, here's the access code, and I was gone. Always know if I ever get kicked off, wait, I will be back. Sometimes it takes up to almost 10 minutes with my internet service to get, it back on. And I just had them here again, changing every cable, and I don't know what. I don't know what more I can do. I have 3 different boxes, boosters, and still. wants to win today? Genesis, you're going to win
Yeah.
today. I know you are. Amy, I think you're it.
Yeah, me.
You think so? I don't
Why
know.
not? I think you could. You were intently listening. I think you got this. Let's do it, all right? Week 5, respiratory cardiac. And they work together. A majority of upper respiratory infections are caused by what? Viruses, 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 viruses. You know, you take your kid to the doctor and they just say Tylenol, Motrin, it's a virus. And you're like, but the kid's got a fever. And in 3 days, the kid's better. You walk into a 6-year-old child room and you find them not breathing and he doesn't wake up. What are you going to do? Again, I told you, go back and look at your CPR, looking at, the exams and all the questions they've added on. They've got CPR questions there for you. I think I've taken it at least 30 times, CPR. So immediately you're going to start chest compressions. It used to be years ago, breathing first and then chest. And now they find out, well, the breathing can wait, but we need to perfuse. So we start the chest. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? It's all the above. They're going to have a fever, the poor appetite, and sitting in the corner not playing, putting their head down in the middle of the day, those things. But vomiting and also abdominal pain, you can see also. Another multi. What do you look when assessing for respiratory function? And I think respiratory adult and, children, there's just all these similarities with all of them. And it's the rate, how fast, how deep, are they labored, unlabored, or is it easy? All of those things to be looked at. The one difference in respiratory that you will see is infants have nasal flaring when they're respiratory distress. And when they're just about to code on you, at the end of a breath, you'll hear a grunt. So the breathing, uh, uh, and you can see them rocking with it too. So nasal flaring and a grunt. That's infants. What would you look for after a child has a tonsillectomy? This is a tricky question. What you're looking for is if they're swallowing more than usual. And why is that? Are they bleeding? If you see a tonsillectomy that is bleeding, they're swallowing. And that swallowing could be your only clue. Because if they're swallowing blood, guess what's going to happen next? They're going to vomit, and then they're going to vomit and dislodge clots. And now you're going to go and have like that little girl I had go into shock because of loss of blood. So swallowing is the biggest look for. A multi. Nursing care for a child status post tonsillectomy include So we want to give them their pain medicine as they need it. Gum is for the older kids because it will help with ear pain. We want to keep them away from spicy food, and an ice bag for those kids who will use it. They used to send these kids home with Hycodan syrup, and now they don't anymore. They only give them Tylenol. They found they were overdosing the children because that's a really powerful pain medicine. Multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Which one is that? And we would treat this usually with a cough suppressant, right? It's always at night. So it's not asthma. Asthma is not a dry cough, all right? It's a little different. What it is your bronchitis. It's bronchitis or tracheal bronchitis. It's the same, it's groupy type thing. And pneumonia is not dry. There's secretions that need to come up. So that is not dry. Multi. What signs and symptoms would you see in a child with otitis media? Over the holidays, I had COVID, and at the end of the COVID, I ended up with my right ear just purulent pus coming out of it. Really bad infection. Never had that before. So, otitis, ears, the pain is intense, okay? Children, they hurt, they have fever, it's loss of appetite. And a lot of times you don't have a fever with otitis. You have a minimal one, usually not a big one at all. And then, of course, any ear drainage is showing you now that eardrum has ruptured, like mine did. The monthly immunization for RSV is what? This is a virus, right? Respiratory syncytial virus. So it is synergist. And why I said virus is, remember that word palivizumab, mab is for viruses. So I believe today they're going to give you the name of it and the classification, so you'll have both there. HIB is hepatitis. Humira is for rheumatoid arthritis, autoimmune diseases. And Indocin is for to close a patent ductus arteriosus. All of the following are signs of early respiratory distress in children except early respiratory distress. That picture, that's what we call retracting to the backbone. I've seen it. When they get to the point of bradycardia, you are about to code because it's tachycardia, dyspnea, restlessness, retractions, and of course, diaphoresis. Bradycardia, as I said, that's the last thing. It's not early. A 4-year-old child's been taking medicines for asthma and they're still wheezing. What information is important to ask? We tend to get these kids and just feel like we have to give them medicines right away and we forget the basics. Are they actually getting the medicine? How are you giving it? Especially when you come to those little meter dose inhalers. If they don't have a spacer, it's hard even for some adults to squirt it and inhale it at the same time. And if they don't, they're not getting it where it needs to go. So you still have these swollen up bronchus, right? An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Tracheal bronchitis. Croup. When you're talking about signs of respiratory, no matter what it is, it's the retractions and restlessness. You know, an 8-month-old respiratory rate of 25 and 108, that kid's perfect. O2 sats 95 is actually excellent. Abdominal breathing, pulse of 100, it's normal. The kid's asleep probably, but that restlessness, retractions, that's what you're seeing because there's obstruction. Signs and symptoms of asthma include all except so they're going to have a cough, they're going to be wheezing, and they're going to be short of breath. They're going to have retractions, tachypnea, all those things. Remember, these children are going to have expiratory wheezing. That air gets trapped in the lungs and they can't get it out. So they're like, "Eh," forcing it out, trying to get it out. Remember, croup is inspiratory. You have the epiglottis obstructing, and then asthma is expiratory. They just can't get it out. And you hear that coming out at the end. Signs and symptoms of congenital heart disease include all except what? You have a heart that's not beating right due to whatever reason. And that's how I would interpret this question. They're not going to be gaining weight because their heart is working too hard, right? Very good. What should you not do to children diagnosed with croup and epiglottitis? So you have this epiglottis that is swollen. It's covering the trachea. You're barking and coughing. And you don't want to do anything to increase that swelling. Leave it alone. Don't look at it. The only person who should look in the throat is whoever has the ability to intubate that child, the doctor. The epiglottis is what? What's an epiglottis? So it's a leaf-like piece of cartilage that covers the larynx when they swallow, and it helps us from choking. It is all the above. Good. Treatment for infectious mononucleosis. All right, so with infectious mononucleosis, you again leave that, protect that tummy. It is a virus, so antibiotics aren't needed here, okay? Rest, and then of course, Tylenol, antipyretics for either the sore throat or for fever. A multi. When doing an admission for an infant with a low-grade fever and a loose cough, what information is important? So you have an infant's being admitted, and you're the nurse, you're taking a history. You need to take care of this child. You need to know their immunization so you know what it, could be or not due to what immunization has been given. You want to know the fever, but when were the meds given? Tylenol, Motrin, when did they get it, right? We need to know so we can progress and give the next dose when it's due. What is cystic fibrosis? So cystic fibrosis is two systems. It's the lungs and it's the small intestines, which is where the body digests and the enzymes are placed. So it's two systems. What is the greatest risk for an infant having a cardiac catheterization? So you've had big old catheters in that right femoral artery and vein, and it can bleed. So it's always worried about that area and that right groin, making sure it's not bleeding because they can bleed out real quick. How is cystic fibrosis identified? Well, we know there's hints to go looking, and as a newborn, that would be not having a stool in the first 2 days of life. That's very unusual. But after we try to figure out, it could be, what test do we do? And that's that sweat test. And what they're looking for is salt on the skin. And I'm telling you, salt is on the skin. And this child is someone you would never, ever limit salt intake on them. A multi. What is included in the plan of care for a child with cystic fibrosis? So we worry about the two systems, right? We have a pulmonary system and the digestive system. And, what are some concerns about it? We're worried about breathing. So it's, of course, taking care of the lungs. And then nutrition, the pancreas is not working that well. They're not getting nutrition and healing. We need protein. So that we need. And then the pancreatic enzymes, help digest. As I just said, you'll never restrict salt, sodium on these children. They're losing it like crazy out of their skin. What is the drug of choice for pharmacological closure of a PDA? So we can do surgical, thoracotomy, and put a staple, or we can give a medicine. It's a 3-dose thing. Which one is it? And this is indomethacin. So let's remember this. Mothers secrete prostaglandins. It's some sort of hormone and it keeps it open. When mom is no longer there and the baby's out, usually no more prostaglandins, it closes. Now, sometimes it continues open. So we use indomethacin, blocks that prostaglandin, and now it can close instead of doing surgery. Synagist is RSV and vitamin K is at birth. What is not a feature of tetralogy of Fallot? Now, I didn't go into a lot of this during the lecture, so I'm going to do some of it right now. Tetralogy of Fallot is when blood on the right side of the heart going up into the lungs. Occasionally, it spasms that pulmonary artery and does not let blood flow into the lungs. Have you ever heard of a blue spell, a tet spell, blue baby spell? This is when that pulmonary artery closes or a piece of tissue covers it and now blood can't get into the lungs. I had one infant. His name was Nolan. I'll never forget him. At 5 o'clock in the morning, I was changing his diaper and just watched his little mouth. And the kid went into a TET spell. He went from 100 O2 saturations to 10, and it was in like 3 minutes. So, how do we treat a tetralogy spell? Well, you need to do something right now, right away. So we do what we call knee chest. I took him, he was on his side. I pushed his head to his knee, and the abdominal cavity changes the pressure in the chest cavity, and it popped open whatever was covering the pulmonary artery and let blood flow back. These children, it's all right side. This is the most tested condition in cardiac. You'll see on HESI and NCLEX. It's all right-sided problems, okay? There is that pulmonary artery stenosis of some type, because when it closes, that right ventricle stretches, so that's called right ventricular hypertrophy. It's a stretching because of extra blood still goes in there. And then they also have a VSD, a hole between the two ventricles, the right and left. And then they call what we could say an overriding aorta. It sort of pushes over because of that VSD there. So it's a 4 thing that we see. It's not aortic stenosis because the aorta is on the left side, okay? What medication would you hold for an infant that's vomiting? The vital signs are 99, 98, 88, 32. An infant, they're vomiting. This is digoxin. I mean, it's a very, clue, but vomiting and they're on digoxin, I'm definitely going to hold it. Go back, check my chart, or tell the parents to call the doctor. Why would the child with tetralogy of Fallot not gain weight at a normal rate? Congenital heart defect. Why aren't they gaining weight normally? Now, sometimes they do surgery right after birth. Sometimes they do it in the first year, and sometimes they're 2 or 3 years old, depending on the doctor and the condition. But tetralogy, you have periods where you're not getting oxygen. So inadequate oxygenation leads to decreased energy. They're not feeding, they don't gain weight. A multi. All are examples of a cyanotic heart murmur, except which one? Which one is not? Which ones? So tetralogy is absolutely cyanotic. Tricuspid atresia, A, without, it doesn't go from the right atrium to the right ventricle, doesn't go into the lungs. So that definitely is congenital cyanotic. Aortic stenosis, osis, there's still an opening. And then an ASD actually has extra pulmonary blood flow because the blood goes from the left into the right side and back into the lungs, okay? I know this is hard. You're going to have to look at it again. What is the most common cyanotic congenital heart defect and the most tested? And it's your tetralogy of Fallot. Truncus is something that Downs get. Everything's just open. And I said that hypoplastic left heart is a bad ventricle, floppy muscle that don't work. Thank God it's not the most common because it's the most devastating of all of them. Tetralogies can be fixed. Nursing care following a cardiac catheterization. So remember, our biggest thing is that catheter, those two catheters and that right groin, and worrying about that bleeding. That's the big thing. So we're going to assess it, and they are on bed rest for 24 hours after procedure, so that clot's not disrupted. You can slightly elevate the head of the bed, as they're awake and start to eat, but slowly. And we never bend the right leg. We keep it straight because we don't want to do anything to pop off that clot that's keeping that blood from flowing everywhere. A multi. Nursing education for cardiac catheterization include all except so we don't bend that extremity and we do not get them out of bed. We are going to look and monitor vital signs and that pressure dressing look at. Which information is the most important when rheumatic fever is suspected? How do we get rheumatic fever? This is strep. This is due to a strep infection that wasn't treated or undertreated or whatever. So, have you had a sore throat recently? Signs of shock in children include all of the following except shock. What do you see? We have low blood pressure and elevated heart rate. That's shock in any age person. You're going to have decreased perfusion, so you're not getting oxygen, an altered mental status, of course, that poor capillary refill, and as I said, elevated heart rate, decreased blood pressure, so hypotension. Which of the following best describes the pathophysiology of Kawasaki disease? The one with the big red eyes. Remember, it is a virus. How do we treat it? IVIG and aspirin for those blood clots. And it's called a multi-system vasculitis, inflammation in the vessels. And we worry about there's going to be an aneurysm in the coronary artery. In fact, one of the first things I like to do when they come in is an echo to look at those coronary arteries. A clinical manifestation of Kawasaki disease is a little bit of everything, and actually it is chorea too. Chorea is those exaggerated movements, and all of them can be corrected. In Kawasaki, the one thing that can't is the heart valve damage, which usually is a mitral valve. What is the treatment for Kawasaki disease? Aspirin and IVIG. As I said, this is a virus. We do not use antibiotics for it, okay? And we need the IVIG to boost the immune system. Which of the following is the most common cause of shock in infants and children? And it's infection, sepsis. Remember, infections really do can really harm children. Their bodies can't handle it, especially the very young ones. So infection, sepsis. What are the defects associated with tetralogy of Fallot? Remember, tetralogy is all right-sided. So can you answer it now? Very good. It's that pulmonary artery has some stenosis, a VSD, that misplaced aorta, and that right ventricle was stretched. Yes, very good. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell? Remember with the infants, I took the knees and then I took their head and I put knee to chest, and it took the abdominal cavity and chest cavity and changed pressures. Older children do the same thing, just like that little boy is doing right there. And it's called squatting. They just squat right down and that changes it, and they do it naturally. Transposition of the great artery is what? This is a child who's going to need their patent ductus arteria open because this child's not getting oxygen. We have oxygen and non-oxygen going in two different circles, and the body's not getting it. It is that switch between the two upper things, the aorta and the pulmonary artery, are changed. And they just do an arterial switch. They pull it up, turn it over, and put it back down, basically. It's an intense surgery, but these kids actually do very well. Which is not an intervention indicated for transposition of great artery? So it's a switch. We're not being oxygenated. What do we need to do? We need to get blood flowing there as best as we can. We need oxygen. It's the whole thing with this. We put them on prostaglandins because we want to keep that patent ductus arteriosus open. We want to make sure that oxygen is getting to the body. The surgery is the arterial switch. Like I said, they pull them up and change both of the vessels. Now, the one thing is this balloon arterial septostomy. What that is you're born with a patent foramen ovale, which is that opening between the upper chambers, the atrium, right? So if they're born with this, they want to make that little bigger because we know if we open it, we're getting more blood flow to the lungs, right? We're opening up the different sides. We don't do anything oral on transposition. This is a very serious thing. Oral vasodilators do nothing. So that's it. A multi. Why is prostaglandins given to a child with prostaglandins of the great artery? You know, that little piece of machinery there is a pacemaker on that little infant in that picture. They do use them. So open up the prostaglandins. We open up the PDA. We help with oxygenation, and then it helps with cardiac output. It is not an antibiotic, has nothing to do with that, okay? So it doesn't prevent anything. It opens up PDA. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? Well, we give prostaglandins to keep it open. I mean, mommy has that, but at birth, mommy's gone. And then the PDA does close by itself, but sometimes it doesn't. So we need to stop those prostaglandins, whatever's there. So we stop them and then the PDA closes. So we're not stimulating or stopping, we're inhibiting that prostaglandin so that we can close that duct with a medical treatment. Where is the PDA? What does it connect? Now, you know it has something to do with oxygen, right? And we know it has something to do with getting it to the body. So, thinking about that, where is it? It's the aorta to the pulmonary artery, okay? Aorta to pulmonary artery. This heart defect allows blood to pass from the left ventricle to the right ventricle. 'Cause remember, it shunts from high pressure to low, so left to right. What is it? What's it called? That is a ventricular septal defect. Comes from the left ventricle to the right. That means there's a hole in that septum. Ventricular septal defect. A multi. What is a sign of digitoxicity in infants? In infants. Well, infants can't tell you they're seeing yellow spots, can they? Nausea, vomiting, heart rate of 90. Infection has nothing to do with digoxin. What is congestive heart failure? The heart's weak, and or there's a kink, and it's not allowed blood to go where it needs to go, so it goes up into the lungs. So you have all of that lungs full of fluid. Left-sided congestive heart failure causes what? If the blood can't get out of the left side, it's bad, weak heart. Where does it go? And what do you see? All of the above. You're short of breath, coughing, tachypnea, dyspneic, fluid in the lungs. Yes, yes, yes. All the above. After a heart transplant, what's the leading reason children die? Rejection, rejection, not infection, rejection. The body says, yeah, I don't like it, get it out of here. And that's why they die. Multi. Signs and symptoms of rheumatic fever include rheumatic fever is caused from a strep infection that wasn't treated, and it attacks multi-systems. Attacks the body, it attacks the brain, it attacks the skin. You're going to have, nodules in the joints, rash, respiratory distress, chorea, all, and then the heart valve. And everything can be corrected with long-term antibiotics except that heart valve. That will need to be probably surgically corrected. A multi. A child's about to have a chest tube removed. What should you do? Remember, some of these kids have 4 chest tubes in, 3, 4 minimum. They don't want the blood to collect in the area and let that heart beat, right? So explain it at their level of understanding. Tell them it's going to hurt. Please tell them it's going to hurt, but you'll hold their hand and please give them something for pain. And vital signs before and after. A child just had abdominal surgery cannot cough well enough to expectorate those secretions. What is your priority when you see that? Just had surgery and can't cough, can't get those secretions out. What are you going to do? This is the one that you're going to medicate for pain. You can try everything else, but I'm not going to move. I'm not getting out of bed. I'm not doing incentive spirometry. I hurt. Medicate me for pain, and I'll probably do all the above, okay? An infant at 3 months has a fever of 103.6. What would you medicate the infant with? You do not give ibuprofen till an infant is 6 months old. There's something to do with blood coagulopathies and bleeding in the infant. They have to be 6 months old. I mean, one dose is not going to hurt them, but it cannot be given. Only acetaminophen, Tylenol. A newborn infant is assessed and you find very weak lower extremities. What should she assess next? So those feet, those pulses are barely there. Like, what should I look for next? What do you think this could be? You're going to do 4 extremity blood pressures. Why? Very weak lower extremities could be coarctation of the aorta. What will you see? Lower blood pressure in the lower extremities and at least 20 millimeters of mercury higher in the upper ones because all the blood's going on the top. That is a question you're going to see. I've seen it on the HESI. A multi. A critically ill child is on complete bed rest. What can a nurse do to help prevent complications? You have children that are sick and for long-term sickness, just because they're a child, they do get complications. They do get things like pressure sores and, rednesses on their skin and foot drops, etc. So complete bed rest, keep their lungs open, spirometry, keep them dry. If they have a diaper, change it, or a chuck, change it. Do what you need to do. And then I've used pillows, blankets, I've used stuffy toys, those little ones, beanie babies, I put for their endotracheal tubes. They could look at them. All of those things, keep them propped and turned. And you don't necessarily have to have the head of the bed elevated, depending on patient condition. How can oxygen be delivered that's the easiest tolerated and accurately monitored for infants? This is last week's question. That's your oxy hood because they can see and they can suck their fingers and have a pacifier. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, they're full of thick secretions. Their lungs are just full of it. I mean, you think lungs of any person that you're worried about that, you're going to make sure that you're deep breathing, that they have chest physiotherapy, they exercise, and they're not going to ambulate PRN. They're going to ambulate TID or QID, not whenever they want. It's going to be more structured. And a multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? So before the meals, immediately before, not 2 hours before, right before. You can put the capsule on the food, make sure you increase that dose, and then if you have powdered, you rinse the mouth. Very good. What is a cardiac defect where there's no valve between the right atrium and the right ventricle? Again, if you don't remember pathophysiology, go back and trace a drop of blood. Knowing the valves, the names, and the flow will help you with the cardiac. And it's a tricuspid atresia. The tetralogy is all about pulmonic valve. Pulmonic stenosis is on the left side going from the left ventricle to the body, and a VSD is not a valve. Last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? Like, what's going on here? Probably congestive failure is occurring. That is it. Listening to that first, you want to check the blood pressure, but probably we're getting filled up with fluids here. Number 3, Morgan. Good job, Morgan. This is a hard one. Number 2, Sarah. Good job, Sarah. Number 1, a KS. Number 4, Miss Vic and AB. Now, that was a very hard Cahoots. A lot of incredible information there. So make sure you go back and look at it. Some good concepts to test yourself on. I will be posting this in a little bit, and I will also take it and put your answer sheet to that cardiac matching so that you have it to look at too. Anybody have any questions? Thank you, guys. If you want an appointment to see me about the exam, please just send me a message and I'll get with